Now we'll shift to our last presentation with Dr. James Giordano, who's going to talk about neuroscience and ethical issues in Havana Syndrome.
Thank you very much. And hopefully you can all see my slides, yes?
Yes, we can see them.
Wonderful. And you can also see me on camera, correct?
Yes, and we can hear you too.
Wonderful. Thank you so very much. So I want to thank very much you for inviting me here. Certainly thanks, Dr. De Cleva, for the invitation, but also a real thanks to Dr. Staub's work for a number of different reasons. It becomes very important to understand that the phenomenon that we're dealing with, what is known as Havana Syndrome, and I have a bit of a problem with that title because I think in some ways it can be derogatory, represents some form of dysfunction of the central nervous system that may have been precipitated by an external event. At this point, as Dr. Staub well noted, it becomes very important to identify what is going on within the central nervous system and what are the constellation of objective signs and subjective symptoms in a rule in rather than just rule out approach. So what I'd like to do for the time that I have end of this conference is reframe this in such a way that's somewhat more summative. In other words, to bring the presentations that you've heard to date into clear light and to certainly highlight a lot of what Dr. Staub has told you about the possibility for multiple forms of neuro and vestibular pathologies to be present, which still begs the question, well, why? What's happening here? And again, what becomes very important for us to understand is that those initial cases in Havana are prototypic cases. Those are cases that have gone through what is now being referred to as the verification and validation pipeline. And as Dr. Staub had noted, those cases were very, very unusual in that they do not represent what appears to be signs and symptoms that would be indicative of other forms of neurologic, physiologic, or even psychiatric and or psychologic conditions or disorders. Something happened there. These were, as you know, referred to as the immaculate concussion, which is not necessarily an accurate nomenclature, but certainly would suggest that there was some form of insult or injury to the head, not necessarily to the brain, but to the head. Our group has been repeatedly referring to this as embassy encephalopathy, which is sort of a fancy way of saying that there's something going wrong in the brain, but we don't know exactly what that is. We don't know if that's the primary source of these symptoms and signs, or if that's downrange, downstream. So a bit of background on this, I think, becomes important. But first of all, it's also very, very important to have a couple of disclaimers. As you all may know, a lot of the work I do continues to be sponsored by a variety of United States government agencies, Department of Defense, Department of Homeland Security, and much of the work that was dedicated to the work on Havana Syndrome that I'll present to you here today grew out of my initial involvement with the case in 2016 and 2017, being called in to do abductive forensic neuroscience for the Department of State, and then subsequently working as Donovan Fellow at United States Special Operations Command. Again, none of the views that I'm presenting here necessarily reflect those of the United States government and any one of its entities, or North Atlantic Treaty Organization, which has also become exceedingly interested in the viability of these types of things to occur and what might produce them. So let's kind of bring these things back into stark relief. It's also very, very important to distinguish what symptoms are from what signs are. And if we're talking about ruling in and ruling out, which is very, very important, that triad, or better still, that triune that Dr. Staub illustrated in terms of psychiatric and psychological conditions and states and traits, but not necessarily disorders, underlying changes in the neurochemistry from the level of the cell to the synapse to the entire system, and then some expression in the neurological realm with regard to cognition, emotion, and behavior represent what we refer to as a constellation. I mean, think of a constellation of stars. One single star does not make the constellation, but if we put them together and we play connect the dots in a particular way, well, then that's constellatory. The same thing occurs here. And this really is the idea of what's probably going on in many, if not all, of these cases. The question here, literally the begged question, is how do we play connect the dots? And are the dots the same? In other words, if we connect the dots in one way, we may get one thing. And if we connect the dots in another way, we may get something else. what's really important to do is to connect those dots in such a way as to link correlation towards some possible causality. Correlation does not imply causality. And I think this is sort of the underlying problem with much of brain science, if you will. At the end of the day, we really don't know how it is that brain produces that great stuff of cognition, emotion, and behavior. We know the gray stuff in your head is responsible, at least in part, but we don't know. The other issue is that very, very small changes in brain function can lead to serious disruptions in thought, emotion, and behavior that then feed back onto the perception of what that physiological state feels like, and as a consequence, then prompt an emotional state, anxiety, vigilance, hyperemotionality. These are important variables to fold into the quasi-calculus of approaching this type of anomalous health incident, and then parsing those signs and symptoms appropriately. Well, if we look again solely to the individuals who were affected in Havana, and if we use that lens as illustrative to then peer at those individuals who may then be or enter into the subsequent verification and validation pipeline, we can see that the symptoms, again, those subjective feelings, first-person feelings, include pressure in the head, a sense of disorientation, inability to cognitively focus, loss of vigilance, fatigue, vertigo, a feeling of tumbling, and motoric difficulties. Now, some of these may be related to others. So, for example, vertigo and motoric difficulties are certainly related by virtue of both correlation and cause. But we also must understand that what's very important to those initial cases in Havana, and will be equally important going forward, those cases that are in the verification and validation pipeline, is the objective clinical signs that cannot be faked, that are representative of some underlying change in the physiology that appears to be structurally or functionally abnormal. As Dr. Staub mentioned, and as others have mentioned throughout the course of the day, these include neurological abnormalities that are tested by virtue of neurovestibular testing in terms of dysfunctions of the connectivity between the small organs of the inner ear, the connectivities of the inner ear with the brainstem, another part of the brain called the cerebellum, and those ascending pathways that process motor input, feeling, sensation, perception, orientation, and then makes meaning of these things in terms of what they represent to the individual, norm or abnorm, comfort or discomfort. And obviously, our position in space and our capability to function when something is going wrong in our physiology can also become aberrant. Now, let me pause here for a moment because there are a number of key terms that I think really must be brought to the fore. And I wholly agree with Dr. Staub's position that, in fact, if you're considering the idea of a functional neurological disorder, this is what is being referred to in contemporary terms as an amphiboly. Fancy term. What it means is that one term or one phrase can have multiple meanings, and extracting those meanings becomes important. But I think it's also important to go back to the future, if you will, as Dr. Staub suggested, which was certainly our recommendation as well. We first began these investigations back in 2016 and 2017. Claiming that there's maybe the presence of a functional neurological disorder is important to distinguish by virtue of the words. A disorder of function within the neurological system. That does not equate with a sociogenic effect. It does not equate or equivalently be equal to a psychogenic effect. This is not necessarily a psychosomatic disorder, although there are psychosomatic signs and symptoms that are present and will be present from various forms of functional neurological disorder. So what we're suggesting here is that something happened somewhere in the neurological axis between the inner ear and the brain, and that there are effects uprange, in other words, within the inner ear component, along that trajectory from inner ear to the various networks and nodes of brain function that process that information, and actually within the brain itself. Well, that said, how does one go about the assessment and diagnosis of what these things could be? Well, we've been through that all day, and again, to reiterate, subjective symptomatic reports, I think, are important. But then it becomes much more important to concretize what those subjective feelings are with underlying objective findings. And these are clinical evaluations of the sort that you've heard throughout the day. Neurological and inner ear examinations, examinations of neurological control of movement and motor function, detailed evaluations of cognitive and emotional processing and capabilities of vigilance, concentration, and psychological state, which is functionally important. And I'll explain to you why in a moment, because the psychological state, the individual's emotive capabilities and emotive characteristics may help to shed some light on some of the underlying neural node and network disruptions. And although that is speculative, interestingly, we know that there have been some reports and there have been some investigations from the experimental all the way to the bedside that have demonstrated that certain changes in vestibular function can disrupt the neurochemistry and then literally produce a cascade of neurochemical changes, the result of which is exhibited in clinical signs and symptoms indicative of anxiety and certain forms of agitated depression. You heard earlier about neuroimaging, and here I think a caveat is important. You know, the neuroimage, and I must tell you, I've been a brain scientist for almost 4 decades. Neuroimaging was an absolute boon. It seemed to be something of a panacea because it allowed us to peer into the living brain, particularly functional neuroimaging. Many of the initial constraints and limitations have been identified and bridged. And there are also forms of neuroimaging that importantly not only look at single sites in the brain, in other words, if you will, certain zip codes and area codes in the brain, but how these are interconnected and what their level of communication is. In other words, examining the networks and nodes and their temporal and spatial interactions. This is referred to as tractography, and it's a very sophisticated form of imaging that would suggest that there may be a functional disruption in the sequence, series, or pattern of the way various brain regions are differentially engaged and activated, which may represent an abnormal state, vis-a-vis some of the Penn findings we saw that suggest not only that there may be some little structural changes that seem to be more representative of something like decompression sickness rather than a concussion, but also functional changes in the way those very specific nodes and networks of the brain process information, not only in the short term, but in the long term. Now, obviously, one of the things we'd look to do is to correlate structure and function. The best ways to do that, you're talking to someone who's trained as neurotoxicologist and pathologist by virtue of anatomy, is to look at things like biopsy or necropsy. That's very difficult, if not impossible, to do within the living brain. Can't take the brain out of someone's head and put it back in. And even biopsying tissue at the level necessary to be able to discern what may be norm from abnorm at that cellular level and that nodal level becomes very, very impossible, and it's highly invasive. There's an ethical barrier there as well, to go probing around within someone's head simply to see if there's something there that may or may not necessarily be present on a neuroimage. The other way to do this is to utilize animal studies and or computational modeling to try to determine what types of things could go wrong in a nervous system, and then back that up deductively or abductively, where you don't have all the information and therefore you're bridging speculation based upon what you know to be able to suggest what might do this. Well, that was an important step because in 2016 and then through 17, 18 into 19, that was exactly the evaluative process. And certainly that process was candidly revealed for the individuals on the National Academy's report, and ultimately was part of the content of what went into the CIA report that was most recently released. We had to examine virtually all the metadata. When we mean by metadata, it's not just what occurred we call in situ, in other words, on site, but also these individuals' prior history, their medical history, their injurious history, their psychological history. The more data, the better. As well, it was very important to correlate the fact that these were individuals who were embedded in an environment and ecology. Could it be that something artifactual or accidental may have occurred with these individuals, even given the best intent, that may have produced these signs and symptoms? Well, the first thing we were concerned about is, well, might there be something psychogenic or sociogenic? And of course, as you heard, the initial presentation and further clarification of the presentation of signs and symptoms is very important in ruling out many of those suspicions early on, and then clarifying that those suspicions were realistically not valid in this case. Break, time out. That's not to say that there are not current exhibits and evidence of a sociogenic and psychogenic phenomenon. Absolutely there are, and we'll get to that momentarily. But it's important to parse, if you will, those prototypic cases from Havana and view those cases in Havana as the lens upon which to view subsequent cases that enter the verification validation pipeline in the appropriate light, with the appropriate shading, and with the appropriate granularity. The possibility was also raised, might it be drugs or chemicals? And there are a number of reasons early on that mitigated those suspicions and then ultimately substantiated that this was not a very strong probability. And certainly, although possible, the probability ultimately came down to a level of almost being nil for a number of reasons: metabolites, environmental residue, etc. The same was true if we were looking at environmental factors. Again, not just drugs, but perhaps chemicals, pesticides, industrial and commercial chemicals that may have been utilized, again, artifactually, with the best intent, but for some reason exhibited certain sensitivities within these individuals that allowed them to present these signs and symptoms. We ruled that out. A number of different patterns mitigated those possibilities and therefore essentially substantiated that that was not the case. So then the question was, what could do this? Well, based upon existing information, research with regard to testing, evaluation, in some cases developmental and applied use, was raised the possibility of some form of directable energy. Well, what type of directable energy? And clearly things that existed within the radio frequency and perhaps electromagnetic range that could be directable via a whole host of possibilities. One is that various forms of both acoustic, that's high sonic, and ultrasonic devices are commercially available for pest repellent. And those devices can also be used to repel human intruders. These are available directly from the internet. There are a number of commercial firms internationally that are available to be able to distribute these products. Could it have been, for example, that an attempt to control pests, whether they were insects or mammalian vermin, that these types of devices may have been installed and utilized in and around the individual's Havana's domicile, where the majority of these effects were incurred? Well, there are a number of reasons here too that mitigated those possibilities and probabilities, not least of which provenance, custodial record, and the types of devices that would need to be used with regard to their locale and the architectures and geometries of the rooms themselves. But what this then allowed us to do is to examine in greater detail the technological readiness level, the TRL, of forms of energy that could be directed in ways that would be scalable, fieldable, and therefore operationalizable. Now, again, please understand that there's information that I simply cannot discuss in an open forum such as this. Some of it exists as confidential, unclassified, and some still remains on the high side. But suffice it to say that information, both at the time, 2016, 17, part of 18, and then subsequently 18 and 19, again, primarily through our work working with international groups in conjunction with Donovan Fellowship at Special Operations Command, revealed that there were two primary domains of directable energy that represented not only state of the science and technology, but were at a point of technological readiness that would allow or enable possible deployability and operational use. The idea of utilizing acoustic rangeable devices in the high sonic and or ultrasonic range, very possible, very probable. The possibility of also utilizing some form of microwave energy, particularly low to moderate gigawatt microwave energy that could be generated using very, very rapid pulsing, perhaps utilizing a light source, a laser source, to be able to develop nanosecond or perhaps even quicker pulsing would allow the scalability, the fieldability, and the containability of microwaves, and also get by some of the power source requirements that might be necessary. Why would such devices be in operation? Well, this too, I think, is a little above my pay grade and out of my sandbox, but suffice it to understand that these types of devices can be used for surveillance and or they can be used either kinetically or non-kinetically for disruptive effects. What do we mean by that? What we mean is that there are a number of nations worldwide that have dedicated effort to employing these devices for testing organic and inorganic substances, primarily from the occupational and commercial range. If we take a look at these nations, they include the United States and many of its allies, China, Russia, among others. So the technology exists. We know the technology is being employed, at least in part, for the evaluation of vulnerability and volatility for organic and inorganic substances. To do what? Well, this is where it gets interesting, because what may be possibly going on here in terms of the actual effects comes to these conclusions. This probably represented, in most, of course, based upon our probabilistic inference, a non-accidental exposure to some form of directable energy source. Acoustic effects, possibly. Could it be an artifact of some surveillance? Perhaps a surveillance effort gone wrong? Perhaps. Might it have been an intentionally disruptive engagement? Perhaps. Could it be some combination of these two above? Yes. But it does also reflect and therefore represent an awareness and knowledge and recognition of the current level of technological sophistication, capability, scalability, and operationalizability. In other words, it is now an important factor to understand that these types of technologies have progressed in the past 2 decades to get to a point where the available technologies, when used convergently, can create devices that are scalable, fieldable, and operationalizable, not for mass destruction, but for rather granular disruption on a variety of levels from the cells all the way up to the socioeconomic. That said, it also becomes exceedingly important to understand what these devices might do. Dr. Staub brought up a very, very important point. In a prior life, I also had background and training in bioengineering and biomechanics. And if we look at the way energy resources, a variety of different types of applied energy might affect different tissues, we have to consider their structure. And there are a number of ways this occurs. Number one is the energy field itself approaches the structure. There's the possibility for an effect known as hysteresis. In other words, the effect in the actual tissue or the structure that is being affected occurs somewhat later than the actual onset or even offset of the stimulus. But one of the things this can do is this can push these tissues or these structures to what's called their non-linear range. So health in any structure or any function is essentially non-linear adaptive. It has a high level, it has a low level, and it doesn't just sit passively in between, rather it moves. But if you apply stimulation to a way that increases the response in whatever that substance is, its functional response, it need not necessarily be destructive per se, but what it does is it then induces a phenomenon called biomechanical creep. Well said. In other words, the system creeps towards its most linear high end, and as a consequence, it resets. Now, when we reset physiological systems, understand they have a structure, a physical structure, and that physical structure begets a variety of functions. Structure and function are interactive throughout our biology. And this is particularly the case in those key functions whereby a structure such as the inner ear directly interacts with neurological inputs and outputs. And it may very well be that by distorting the structure and its function, we then hyper-engage those neurological feed-forward mechanisms to then have what's called a hyper-excitatory effect. Interestingly, one of the things we know that occurs in many forms of structural and functional vestibular disorders is that the nature of the inner ear disruption can actually cause neurochemical changes in the brain. This is not a lecture in neuropharmacology or neurochemistry, but if we look, quote, downrange, one of the things we find is that increased excitability within the neurovestibular pathway can increase the activity of glutamate, an excitatory neurotransmitter, in a number of different brain nodes and networks, inclusive of those that process vestibular input and the coordination areas of the brain, inclusive of an area called the insula and the anterior and medial cingulate gyrus. As the glutamate function increases, one of the things that can happen is that you then see an overlevel of excitation. It's called hyperexcitosis. And as a consequence, those individual nerve cells and nerve networks reset themselves in a way that is now abnormal or disruptive. Curiously, what we also know is as glutamate levels tend to increase, serotonin levels in the brain, in those key nodes and networks, seem to be decreasing because they're not able to keep pace with that level of neurochemical imbalance. Please understand, that was a very, very simplistic explanation of how these pathways work. And we can't reduce everything down to simple neurochemical imbalances. But it is noteworthy that those antidepressant drugs that are highly serotonergic, that work as serotonin transporter inhibitors and or that work upstream, have also been shown to be highly effective against various forms of persistent postural vertigo. And also by reducing some of the sympathetic nervous system activity that can occur in result of vertigo, can also bring back some of the cognitive emotional stability. And this, of course, we know is important. So one of the things that we're considering is that you're not really seeing one thing or the other, that you may have seen some form of structural disruption that may be caused by vibration and or distortion incurred through some form of directed energy that may have produced ripples, if you will, effects, anomalous effects downstream within the nervous system to reset the nervous system in those ways that now disposes that individual towards the types of things we see with these forms of vertiginous defects as described by Dr. Staub and others. So the question then becomes, could these technologies do this? Yes, they could. Could these technologies also induce something which has been referred to earlier in the chat as the fray effect? And in part, yes, they could. What you see here is that any of these technologies, the sonic technologies and or the non-thermal microwave technologies, are capable of inducing an energetic disruption in either solid tissue or in fluid tissue. And certainly, please understand, you have both solid and fluid tissues in the deep inner ear as well as in the brain. And that causes those tissues to roil, to sort of bubble. As a consequence, that bubbling leads to instability. It's referred to as a cavitation effect. We also know that some of those cavitation effects are possible to be translated not only from the fluid of the inner ear, but from the bloodstream of the inner ear to the vasculature that then goes into the brain, particularly the forward area of the brain, in and around the branches of the cerebral artery that also affect one of the areas that is, in fact, a target area, the insula. Is it possible that the combination of these effects produces this constellation of features? And this is what we're seeing on a level from the cell all the way to the systemic, and on the level from the very personal all the way to the populational. It is. Is that speculation? Yes, of course it is. Is it speculation based upon modeling? Yes, absolutely. But one of the things that becomes equally important is to resort to something called ex ubantibus reasoning. In other words, if we have certain interventions, treatments, if you will, and we know how those treatments work, and those treatments are effective in individuals who are presenting with certain signs and symptoms, well, then one can create, if you will, an analysis, an analytic conclusion that something that those treatments are doing are affecting that mechanism we know those treatments work on, which may have gone wrong in these individuals. Is there room for error there? There's always room for error. Is it therefore possible, and thus based upon the efforts to date and the metadata coming not only from the patients in Havana, but some of those who are in the verification and validation pipeline, that the effects that they're seeing in terms of their clinically observable signs and the symptoms that they produce may be due to an incurred effect by some form of external stimulus that was able to disrupt inner ear and inner ear to neurological functions in one or more ways? Yes. So what do we do about it? For those of you who are into philosophy, the question here is, how do we shave with Occam's razor while sailing in von Neurath's boat? In other words, how do we try to keep the approach simple while we've already launched? Let me explain what I mean by that. It's important to understand that if nothing else comes out of these cases in Havana, and all of the media and attention that has been subsequent to that, must be an awareness that the science and technology has advanced to a point where such tools and techniques are usable and deployable in non-kinetic and kinetic operations. This is not new. This is not magic. We've known this for years. We've seen the technologies as viable for years, and many of the constraints and limits for the actual deployability and usability of these technologies have been bridged, have been compensated for by bringing several technologies together with regard to things like laser science, nanoscience, the use of various forms of engineering, and a more detailed understanding of how the brain and or physiological systems work. So what we've called for is that in addressing these, we do this in a way that is practically wise. Fancy term here, coming from Aristotle. Aristotle called practical wisdom phronesis. And what we've called for is a phronetic approach. And how it works is quite simple. Any ethical address, analysis, and articulation of what could be done and what should be done must proceed from fact. One of the facts is that there are abundant cases that reflect a sociogenic and psychogenic phenomenon. Individuals who are the worried well, individuals who conflate signs and symptoms of pre-existing or current other disorders to be possibility for Havana Syndrome, individuals who may have some form of psychological overlay. It becomes important to distinguish those clades of signs and symptoms. And it becomes equally important to understand that the possibilities certainly exist, that there are technologies out there that are capable of inducing these types of disruptions. And therefore, we need to increase the granularity, specificity, and sophistication of how we look. As Dr. Staub said, this is a 21st century problem. 21st century problems demand 21st century address and answers. Obviously, the ethics must be devoted to the enterprise. And if we're talking about something that has both a public health component as well as a national safety and security component, then please understand that those directed efforts may not necessarily always be transparent. What must be transparent is the directive, intent, motivation, and dedication to, in fact, apply efforts, energies, and endeavors towards getting the necessary address, acknowledging the problem, coming up with answers, and finding solutions. Why? Because realistically, we understand that these things are out there, and therefore we must develop those techniques and technologies that are far more sophisticated and capable in evaluating if and when such types of technologies are being utilized against individuals in a variety of different settings, from bellicose combative settings to more terrorist type public settings that equally have value with regard to creating a disruptive effect, but can also create a tremendous psychogenic and sociological effect based upon the ripple manifestations that can occur among, again, populations of the worried well as just the disruptive effects of not knowing if a particular thing has happened or not. Clarification and awareness is critical here as a first step. The second important step is quantification. What really is the actual quantifiable burden, risk, harm, and threat of these types of things occurring? And obviously, how do we then detect it? Well, much of what you've heard today, inclusive of the past two lectures, have addressed possible underlying physiological mechanisms. And I've described to you those most probabilistic inferences of what kinds of things could cause these. So this throws down the gauntlet of both challenge and opportunity to develop programs and projects to create devices for detection, mitigation, and prevention. And the good news is that such efforts are currently underway, not only here in the United States, but worldwide. But again, I think this also bespeaks the idea of practical wisdom. And along with this, I think one must appreciate that there needs to be some degree of relative or non-transparency. Let me explain why. This is not saying that these things occur in dark laboratories hidden away somewhere in malevolent ways. But let's face it, if one of the things we're acknowledging is that there are techniques, technologies, and science that are available on the global stage that can be rendered and utilized via a variety of actors, whether they're state actors or non-state actors, to incur disruptive effects. What you don't want to do is open your playbook on Friday and truly expect to win the game on Saturday. In other words, understanding what's going on, understanding the technology readiness level, and then developing the necessary responses may not necessarily be the most fully transparent paradigm. For simple reasons is that you don't want to throw your cards. What we've called for is something called prudent parentalism, not paternalism, parentalism. In other words, it becomes important for those institutions, organizations, individuals, and resources that are working in these protective ways to assure those that they are protecting that such protective efforts are underway. Think of a good parent. What the good parent does is informs, as best possible to the level of understanding, and at the same time informs so as to continue to keep that individual they're protecting out of harm's way. This is not always as easy as one would think. I mean, clearly the idea to fight for right and freedom, but at the same time keep your honor clean. Well, one of the issues here is that there may be something of a technology brinksmanship, if you will, a science and technology race, whereby one group makes one set of discoveries and creates certain types of technological readiness. And then the response is that other groups must in fact play catch up. And clearly what this then implies is that there is some form of an ongoing effort. So what we have called for is something called a care concept, which is the considerate articulation of realities, responsibility, and expectation. And what I mean by considerate is be considerate of all the variables. Certainly most considerate is the primacy of those who are being affected, those who have been harmed, those who have been burdened. That's critical. But equally considerate is how we then acknowledge and respond to those things in ways that do not increase the potential for further risk and harm, not only to those who have been affected, but to others. Reliable and responsible treatment of the individuals. Dedicated, ongoing programs of surveillance of neuroscience, technology, research, developmental test and evaluation worldwide. Transparency as to what's going on in those programs by virtue of, in some cases, cooperation and collaboration, even with international competitors. Certainly public communication of the process, which is why I applaud forums like the one we have here today. Responsible oversight, governance and control, and the engagement of multidisciplinary advisory groups, such as the national academies that address these anomalous health incidences. But more than that, understanding the science and technology is making inroads, and those inroads can be used in a variety of ways, some for healing, some for harming, also puts incumbent responsibilities upon the current and future iterations of things like the Biological Toxins and Weapons Convention. And here I'm enthused and optimistically can report to you that a number of groups, most notably the Australia group to the review committee of the Biological Toxins and Weapons Convention, has advocated that now we begin to consider these devices and these technologies as potential bioweapons. And I'm proud to say that some of the groups that I've worked with, the National Defense University, at the Naval War College, within the DoD, Special Operations Command and intelligence community, have also called for a change in the posture of how the language of these treaties is devised, developed, articulated, and sustained. But equally important is the fact that these techniques and technologies have become ever more the province of multiple nation states on the global stage. And therefore, that ongoing level of multinational surveillance and engagement is critical, but so is an appreciation of the various socio-cultural factors that would propel various nation states to engage in this type of research, number one, and to possibly use it. Understanding that tools are out there, that the science exists, is not the same as saying the science is being used. I mean, it's one thing you don't want to say, well, the sky is falling or crying wolf. You don't want to do that. But you do want to take a look at the clouds and say, you know, today looks like rain, and what are we going to do to prepare for it? So what we're calling for going forward, quo vadis, is to cash this thing, the reality check, with regard to our perspective, our humility in that science by its nature must be self-critical and self-revising, and at the same time, the scientific approaches to not only detection, mitigation, and prevention, but how we treat those who have been affected with something must remain equally flexible, equally humble. And certainly, I think there's a sense of gratitude for the achievements that have been accomplished so far, to put them in the proper perspective. What this actually calls for, ladies and gentlemen, is that we adapt those procedures that work, if you will, left of bang. To understand what bang are the risks, harms, and threats that exist, and it becomes increasingly important based upon our awareness of the sophistication and capabilities of the science and technology to employ equal effort with detailed endeavor and enterprise to, in many ways, define how that science and technology could be so used, both beneficially as well as bellicosely, to understand not only the benefits, but also the burdens and harms that could be occurred by various uses of those technologies, and then to also be prepared. Prepared means readiness, Readiness means not only qualification, identification, and awareness of the risks, threats, and harms, but also vigilance, preparedness for detection, mitigation, and prevention. Because the thing we don't want to do is we don't want to devote efforts to science and technologies aimed at unraveling this sort of Gordian knot of the way the brain, the nervous system, and our physiology functions, only to open a can of worms in the way that these techniques and technologies could be used, might have been used, and may continue to be used in ways that are damaging to individuals, to the public, and to national safety and security. For those of you who are interested in our ongoing work, not only dealing with the Havana Syndrome since 2016, but addressing some of the capabilities of neuroscience and technology, along with other areas of bioscience and tech that could be applied in these ways, and what needs to be done to address and mitigate these risks and threats, I provide that information for you here. And for those of you who wish to get in touch with me, please feel free. You can reach me at james.giordano@georgetown.edu. And with that, I'll stop sharing my screen and open this up for the possibility of questions if we have any.
Thank you, Dr. Giordano, excuse me, for a fascinating presentation. I'm going to paraphrase a couple of questions that go along some of the themes that you've articulated, particularly in the last part of your talk. One is, are there any sensors being developed that can sort of, in a proactive way, as shown in your last slide, help mitigate against these type of technological threats, things that you're able to comment on in this open forum? And secondly, have any scientists done further work in terms of trying to replicate a device that can mimic this and be ethically tested, similar to the device that the two University of Michigan engineering students developed back in 2017 to mimic the sounds that somebody had posted on the internet that they thought were the sounds they heard?
Yeah, so let me just speak first to the idea of the sounds, and it sounded like crickets. So the sounds appear to be an artifact actually of the waveform based upon the architecture and geometry of where the individual was relative to the, if you will, incurring stimulus. We know, for example, that rangeable acoustic devices, particularly those in the high sonic and ultrasonic range, have a very specific cone of effect. But if you move outside of that cone, or if you move in such a way as to divert or to distort the architecture and geometries, there may very well be, if you will, an auditory effect, a palpable sensory acoustic effect. And this was alluded to earlier. In other words, it need not necessarily damage the tissue. It only takes the tissue to its upper limit, and as a consequence, then distorts the function and structure of that tissue and therefore resets it. That may be palpable, that may be tangible, that may be sensed, and that may be part of the thing that people have heard, so to speak. And again, there's individual variation based upon a whole host of things. Literally, the shape of the skull, the architectonics of bone, coupled with the architecture and geometry of the room, and where these individuals were moving with regard to the biophysical wave. But it's important to understand that in some cases, there may be an acoustic signature. That acoustic signature may be auditory or may be para-auditory, but that then brings us up to the prior point. Could we utilize some of these characteristics as viable criteria for detection, number one, and number two, mitigation? The short answer is yes. The intermediate answer is I'm very encouraged by some of the dedicated efforts most recently that I've become aware of. And the longer answer is obviously that information at this point remains at very, very least confidential and unclassified information, and at most in the classified space. And you would imagine that this could or should not be discussed. Suffice it to say that efforts are underway, and I'm encouraged by those efforts that I've been aware of to date.
We have some other questions. We have a question: what steps would you recommend for civilian patients who've been given diagnoses similar to those of embassy personnel by Dr. Hoffer and his group in Miami?
Yeah, that's a very, very good question. And I must tell you, I receive a number of emails and a number of correspondences from individuals who have reports in which they're reporting certainly symptoms and in some cases validatable signs. I think what becomes very, very important is for them to seek clinical assistance, seek clinical aid, first and foremost. Why? Well, clearly they're suffering, something is wrong, find out what is wrong. That also helps to provide objective evidence that there are dysfunctional parameters and abnormalities, which would then be important to feed, if you will, up the chain. So these could then be further evaluated. And there are a number of evaluative programs, as we know, operative right now in the United States, into which that information would then be uptaken. So the individuals might then progress into the verification and validation pipelines.
Okay.